Welcome to the Ripple of Change podcast, searching for our quadruple aim, where we highlight, celebrate, and extol others creating positive change in healthcare and beyond. I'm your host, Dr. Otten, and today's topic is avoiding the status quo bias. GPT MD meets BAMF Health. I am joined today by two brilliant change agents, Dr. Anthony Chang, who's the founder and CEO of BAMF Health, Bold Advanced Medical Future, the world's most advanced therapeutics center. BAMF Health is the world's first vertically integrated platform for molecular imaging and radiopharmaceutical therapy. And our guest today is Dr. Robert Pearl, author of several books, including Mistreated, Uncaring, and GPT MD. Now, I will admit, I have not read all three, but I have read this one, and it was fantastic. So for those of you listening, I'm holding up GPT MD. I highly recommend it. And not only is it a great book, but the proceeds are actually going to benefit Doctors Without Borders. So what a fantastic way to facilitate even more positive change. In addition, Robert is a Forbes healthcare contributor, Stanford University Medical and Business School professor, and former CEO of the Permanente Medical Group, Kaiser Permanente. Gentlemen, it is a true pleasure and honor to have you both here today, and I'm super excited for the opportunity. I'd like to start with a question to you, Robert, if I may. How does generative AI differ from other types of AI?
Thanks for having me today. Generative AI is what I think of as a third generation of AI. If you look in the late 1900s, you see rule-based AI. This is when clinical experts, and I'm talking in medicine right now, put into computer systems what are called algorithms, ways to think about heuristics, short rules of thumb about how to answer questions. And it does it well, but it was never as good as the people who entered the data because a few heuristics can't possibly match human intuition. That all changed around the year 2000. And computers started to have what I like to think of as a biological architecture. It was based upon how our brains function with what's called neural nets. It allowed deep learning to occur. And what would happen now is that, let's say, in the mammographic area, a difficult to interpret breast cancer study, they would take 5,000 mammograms that showed cancer and 5,000 that were normal or had benign problems. And then the application itself, in ways that actually the programmers couldn't fully understand, would come up with 50, 70, 100 different slight differences. It would assign probability factors, and it would be able to not only interpret mammograms, but do so about 10% better than radiologists. The challenge of narrow AI, first, is that it requires these large data sets, and they have to be very accurate. And the electronic health record is not accurate today, by which I mean that you could have two patients and both have pain, but the difference in pain, the subjective difference is so great, the application can't figure it out. And if there's an error in that, it's going to be leading to negative, improper outcomes. And second of all, it's narrow. You can't use a mammogram AI tool to read x-rays of the chest or brain. Around 3 years ago, OpenAI released ChatGPT. And I want to tell listeners, I have no financial connection with any of these AI companies. I just interpret what I can read in the literature and in the research that sits there. And it's a completely different methodology. It starts with all of the information available off of the internet, every medical textbook, journal article, and having been what's called pre-trained, it's then given parameters. Information that's more current is more significant than older information. Information from peer-reviewed journals is better than information from random journals. Information from major academic institutions like the Mayo Clinic or Johns Hopkins or Stanford is seen as being more likely to be accurate. And then it can answer any question. And what's most significant about generative AI and I no longer call things AI because they are so different, is that now the patient can be empowered. It's why the subtext of the book, ChatGPT MD, is how AI empowered patients and doctors can take back control of American medicine. Anyone can enter information and obtain what I think of as expertise. And in other areas, these large language models allow you to paint like a Rembrandt, even though you've never had an art course, program a computer, even though you've never had an IT course, write music in the style of Drake, even though you don't play an instrument. And it can allow patients to become active participants in their own healthcare. And this will be revolutionary and transformative.
I think that's brilliant. And I love the concept of empowering patients. In fact, I mean, I wrote a book with a patient that I can see sitting behind Anthony, and forgive my oldest child for walking in on me as this is going on, but I suppose that adds a little bit of levity to the show. Anthony, I would love to hear from you about BAMF Health and how you are using AI and actually delivering therapy to patients with particularly metastatic prostate cancer.
Yeah, this is definitely a very exciting topic, and we're on this journey almost about 9.5 years ago when AI is not even really a thing or well accepted and heard by general public. So the problem BAMF Health is trying to solve is trying to bring a brand new technology called radiopharmaceuticals for both diagnostic and the therapy to the patients. Using these radiopharmaceuticals, this will allow us to see the diseases current cannot be seen right now, and we can catch a disease way earlier, stage patients more correctly, but we also be able to treat patients more precisely, like end stage metastatic cancer, without causing any significant side effect. But the key is we need to be able to quickly analyze these kind of images, and not only like a conventional radiological report offer qualitative report, say, hey, yes, we have a likely 100 tumor, a lot of tumor, in massive tumor in these patients at this kind of location. We need to have a quantitative analysis for every single tumors and in patient's body in order to make the right decisions about how much dose we want to inject into the patients for treat this patient effectively, and also using this kind of information to predict the prognosis of the patients. So in order to do that, as you can see, especially you're trying to treat in large the patients with the cancer with a lot of population, like a prostate cancer with 3 million patients in the United States right now, you cannot asking doctors or medical professionals to do these kind of things tumor by tumor, patient by patient. It's just not feasible. And then so AI will play a very, very important role over here, allowing us quickly to review the images, generate a report, do the quantitative analysis, and turn these kind of useful information into useful intelligence. Then allowing doctors using this kind of intelligence to make the right medical decisions on how to treat the patients. So what we're doing over here is we have a AI team focus on this field, develop all the AI about the tumor segmentation, normal organ segmentation, to do the quantitative study, generated the structured radiological report to help doctor quickly review what the status of the patients. And once we have this kind of information, doctor can use this information to decide if this is right patients to receive this type of therapy, and how much dose we should inject into the patients based on the tumor burden and the number of a target instead of just the body weight. And then on top of that, 24 hours later, we have technology allowing us to see if the drug get into the tumor and how much drug get in each tumor. So the AI algorithm over here can come out with a comprehensive dosimetry map for each tumor. So we will know if the tumor receive enough radiation dose for this round of therapy. So which tumor will disappear, which tumor will remain there. Therefore, we can decide if this patient need another round of a therapy or not, and how much dose we will need to give the patients for next round. So this is what we're in a very, very high level, how we use AI to improve patient care, not significantly improve the efficiency of the treatment, but it also significantly improve the accuracy of the treatment for patients. And on top of that, like what Robert talked about, using generative AI to create some content on the note and will allow doctor and patients spend more time to really understand like what really going on in patient's body and about this kind of therapy. And this is a very, very powerful tool, allowing medical professionals to do their job more efficiently and only do the value add things instead of just tedious routine process.
This is so amazing because you can see it from like both perspectives in terms of how AI is not only helping deliver care, but then also from the patient's perspective, understanding it, assimilating it, and really facilitating potentially the appropriate treatment. I found it fascinating, the concept, Robert, and I'm going to put this back to you, where the patient would be more empowered when they came in to see the clinician. They, instead of just going to random websites and maybe getting good information or not, but assimilating that into something intelligible that they could then have a more concrete discussion, but in a language that they would understand, right? I would love your feedback on what Anthony's got going on, or really anything. Hey, the floor is yours, sir.
So what Anthony's talking about is very sophisticated advanced medicine. And as he points out, that the AI tools can allow us to be much more precise for individuals. And in many ways, I'm writing from the standpoint more of the patient, although in the book, I do talk a lot about the 400,000 misdiagnoses that kill patients every year in the United States, another 400,000 that lead to long-term permanent disability. And a lot of it comes down to clinicians being too rushed. And so this is where I see the patient stepping in. And as you said in your introduction to this question, far more than a Google search or clicking on a bunch of links. One way, as you note, is to be able to be educated when they see the clinician. I was on a different podcast a few weeks ago, and at the end, after we were off the recording, the host said to me, "My husband fell skiing a couple of months ago, and his hand was over his head and he slid down about 100 feet and his shoulder still hurts and he can't use that side as well as the opposite side. You're a skier, you're an expert in medical problems. What do you think's going on?" And I said, "Well, I think I know what's going on, but I'm not going to say it right now. Why don't you use ChatGPT? You've never used it before. Put all the information you can think of into it and see what it says, what kind of recommendation it gives you. And if you still have questions, give me a call." And 5 days later, she got back to me and she said, "Thank you so much." What I was able to diagnose was the ChatGPT said, most likely he has a rotator cuff tear. He'll need an MRI to establish the diagnosis, and he should see an orthopedic surgeon because he most likely needs surgery. Not just see an orthopedic surgeon because that's a safe response. No, a very specific one. And she said that's exactly what happened. Went to the surgeon, ordered the MRI, made the diagnosis, did the surgery, and said that had we not come in for several more months, he might not have been able to repair the tear because the muscle could have contracted. So that's obviously a major opportunity. But the biggest one, the one that I think will save hundreds of thousands of lives every year, tie into the issue of chronic disease. These are things like hypertension, the number one cause of strokes, or diabetes, major contributor to kidney failure, to heart failure, to 80% of peripheral amputations. And you would think that as a nation, we would do well in this. I mean, Anthony's given examples of very complex microdosing issues with sophisticated nucleotides, but we do a poor job when it comes to managing chronic disease. And by the way, 60% of Americans have at least one chronic disease, and they account for at least 70% of healthcare costs today because their complications are heart attacks, strokes, cancer, kidney failure, and the peripheral amputations that I mentioned earlier. And the problem is we use an outdated model. We use an acute care model where if I see you with a, let's say, lower right quadrant pain, and I diagnose appendicitis, I take your appendix out, you're fine. I don't have to see you again. Chronic disease, you have for the rest of your life. And we manage it in an episodic way. I see you in the office, I diagnose hypertension, And then I say, here's a medication, I'll see you in 4 months. I have no idea what goes on in the interim. After 1 month, I should be able to tell what's going on. We have monitors these days that are 99.9% reliable, inexpensive, and yet clinicians don't use it. And why is that? Because if we do 100 measurements in, let's say, a 1 month time period of blood pressure, and 92 of them are normal and 8 are abnormal, does that mean you're doing great because 92 are normal? Do you doing terribly because 8 are abnormal? You don't know as a patient. The clinician doesn't have time to review 100 readings. He or she doesn't want to have their electronic record filled with all this data. No. What ends up happening is we control hypertension. As I said, the number one cause of strokes, major contributor to kidney failure. We control it 55 to 60% of the time. And diabetes, and by the way, we're talking about a third of Americans, we control it 30% of the time. The question is, how could we now engage the patient? Have the ChatGPT or whatever other Gemini or Claude, whatever other generative AI tool you like, evaluate how you're doing, giving you feedback. And after 1 month saying, you haven't responded the way your clinician said you should. And either you should call the clinician or I can send a note to the clinician. Your insulin levels need to be changed because your blood sugars are bouncing all over the place. We move from episodic to continuous care. And according to the CDC, if we could control chronic disease the way that we know that we can today, not some theoretical outcome of perfection, we'd reduce heart attack, strokes, cancer, kidney failures by 30 to 50%. And I want you to think about what would that do to the health of the nation? And how much more would that make it affordable? And how much more time would it give to clinicians who today have to see a patient every 17 minutes to spend the in-depth time needed? We would have a far better healthcare system with better outcomes and more beneficial for the entire both medical and financial health of our country.
I think this is fascinating. And as a family physician, I can speak all day really on those 15-minute visits and what we're trying to accomplish in that setting, congestive heart failure, diabetes. Oh, by the way, your PSA is elevating and they're depressed and they can't pay their bills. And what about the insurance? And I mean, it's a nightmare. And we wonder why we're having clinicians leave in droves, right? Interestingly enough, Robert, I think two of the things that really caught my attention, and probably there's some bias related to that on my part, were some of the comments about the importance of primary care, which certainly resonated with me. And we don't need to get into that necessarily. I'm going to bounce this next one over to Anthony, but also the changes that we need to see in leadership and the courage to think outside of the box and to do things differently, to stretch our boundaries and to consider using generative AI in empowering patients. I've known Anthony for a couple of years now, and I think he's an amazing leader and clearly doing some things that are, challenging the normative in terms of devastating disease, particularly prostate cancer. Anthony, I guess I'd like to hear from you. How do you feel being perceived as a leader and helping walk down this path of different treatment modalities? I mean, that's not something that we're all prepped for. Like, hey, lead the nation down this path and a new treatment modality. How do you feel? I'm trying to pick your brain a little bit open-ended question here.
Of course, it's a great honor to do these kind of things, and because I feel like we can get every day is one step closer to get to where we want to be to benefit and serve the patient better. But on the other hand, the reality is like just hit wall every single day. It's a very, very tough position. But that's exactly why leader has to be here to lead. And I think Robert just mentioned a very, very important key point. It's not just the behavior has to change, but the most important part is actually the mindset need to change. I mean, right now we have a lot of great technology, and if you're really willing to sit down to look at and think about the potential impact to integrate the AI into our daily practice in so many disciplines, it's not hard to see this kind of obvious impact, positive impact to the patients, to the system, to the physician. However, a lot of time, people just stay when people stay in the system. They're either they don't have time, they don't have a bandwidth to sit down to think about it, or the system or regulatory doesn't allowing them to actually make this kind of change. So they just feel like a powerless to drive these kind of things. On top of that, they still have a lot of life need to be saved right now. And that actually slow a lot of process down, and also like a limited what we can do over here. So I think the most important part right now is, I think the biggest problem, and that's another thing that I want to ask Robert, is like what's in your mind, like how should we change the mindset effectively, so allowing more people can embrace this technology and really make it a significant change, instead of just like a small group of people like us really experience that, see that, willing to use that, but it doesn't really make a big difference in the overall infrastructure, or take a way longer time than it's supposed to be to make an impact.
Your question is a great one because, as I said, or as Todd introduced me earlier, I teach at the business school, and I can tell viewers and listeners there are thousands of great ideas out there. There's no shortage of great ideas, but translating strategy into operations. I tell people strategic thinking without action is powerless. I teach strategy at the business school. And that is often the hard part, as you're noting. And in this area, I'd separate into two different components. There's the patient, and then there's, of course, the clinician. I think the patient part will happen naturally. This is the arc of technology. We always see it when the ATMs came out. No one would want to put money in there. How did you know to ever get it back? How did you know it wouldn't be stolen from you? I mean, there was tremendous fear when the automobile came out. People were very afraid of this monster on the roads. We could go through every technology, every major technology, but over time, the good ones do very well and people embrace it. It makes their lives easier today. Today, people don't even bother going to the ATM. They're going to do it over an application on their iPhone or some other type of device that's going to allow them to be able to manage their finances with, at this point, great confidence. But clinicians are different. And I think there's two aspects to this. The first one is clinicians appropriately are afraid of harming a patient. So new technology that might be negative, and generative AI has downsides to it. It has areas in which it hallucinates, and that's why it's not yet ready to do some of the things I talk about, but it will be in a couple of years. It's doubling in power every year. It'll be 30 times more powerful in 5 years, 1,000 times more powerful in a decade. It has that opportunity now if leadership can bring clinicians along. And in the book, ChatGPT MD, I write about one aspect of it, which is the economic. I mean, if we reduce heart attacks and strokes and cancers by 30 to 50%, people are going to be worried. What's going to happen to my income? How can I support my family? It's not negative. It doesn't really go against the grain of medicine. It's just a natural human response, the protective response. So we have to be able to address those fears by changing the reimbursement methodology, which I think may be the biggest problem when it comes to generative AI. Because if you're going to prevent the chronic diseases, better manage them to avoid the heart attacks, strokes, kidney failure, the cancers, we need to make sure that people are rewarded for it. It gets back to Todd's point. That's why primary care is going to have to be elevated, both from a cultural perspective and an economic one, because they're going to have to be a major player, far more than today, into this future. And we don't have the time on this show, but in the book, I talk about the A to G model, about how leaders bring people along. They create an aspirational vision. You got to win someone's heart before you can win their brain. And an aspiration has to be both inspirational and it has to be realistic. And that's what it is with generative AI. We already can see it. I have hundreds of stories of successes where people have applied it and avoided a major medical problem. These are specific behaviors. Doctors are going to worry. Am I going to be up all night? Am I going to be constantly called 24 hours a day? No. How do you have systems to be able to handle the information when the generative AI tool helps patients identify that the chronic disease is not being managed well? They're going to worry about that. I have to spend an hour teaching generative AI to every patient. No. How do we have videos, or how do we have classes or handouts, depending upon the modality the patient wants? What's the context? I mean, people like you and me are always dealing with what's going on in the United States with the healthcare system, the fact that we spend twice as much as any other nation in the world with outcomes that lag the other 12 peer nations, the 400,000 people who died from misdiagnosis, 250,000 dying from medical errors, preventable medical errors, maybe 2, 3, 400,000 dying from chronic diseases that should have been either prevented or better managed. This is the context. And once people understand it, they're going to be more willing to embrace it. The data, the reliability information, engagement of leaders. Leaders are going to have to lead the way. They're going to have to be the ones to demonstrate that they can use it in their clinical practices and the work that they do. It's going to need faculty, people with IT expertise to help support them. And it's going to need to have the proper incentives so that we recognize that if we don't incentivize and reward prevention of disease as much as intervention, we are going to be in a situation where people are just not going to value it high enough. And the good part is that if we could take out the cost of those avoidable heart attacks, strokes, kidney failures, cancers, we will have a lot of money that we can reassess, reapply, some on behalf of our patients to lower their costs, because half of Americans say they can't afford healthcare today, and some of it to reward the clinicians who are now doing this work, and overall be able to make healthcare affordable for the American populace, which today increasingly it is not.
I just love to hear what Robert just said. I think if I summarize it correctly, I mean, for leadership wise, I mean, in order to make people make behavior change, you need to win their heart and then change their mindset, and they're going to have a behavior change. But it's not just this part. We also need to make a systemic, structural change, like with the right incentive and the right regulatory, allowing people have more incentive to really practice this new type of medicine. And overall, when we combine these two things together, and we can really make it a change. And I really, really like this kind of concept, because I have no doubt. I mean, we are going to adopt AI in medicine field, and we're going to use them heavily in medical field. It's inevitable. The question is how fast we can get there. It may take 30 years, or we hope it can take 5 years. But that's the question we really need to think about, how we can make a collective effort to really start to follow what you just talked about, heart, mind, and behavior, and start to convince the leaders to start changing the system and start really jumping over there. There's actually two things I also feel like as what I observe as a roadblocker for people to adapt AI in medicine. One is from the patients, one is from the clinicians. Clinicians, we observe a lot of clinicians, we are trained to be very, very relatively conservative, right? If the FDA is not approved, and then we will not, a lot of people will not encourage people to try these kind of things, or at least we need to put some note over there. This is not FDA approved and off-label use, something like that. So take the Alzheimer's disease, for example. Even we have two drugs just get approved by FDA the past 2 years for Alzheimer's treatment, but the majority of neurologists in the field still sit back to watch, because they don't just say because FDA approved it, I'm going to use it. They want to see what's overall behavior and response for patient in the early phase, use it, and how they respond to these kind of things, then they're gonna adopt it. So that's one thing. For new technology, physician will like to sit and watch. Don't be the first one put their heads out of the trench, and now we may want to change that. And the other one is actually the patients. There's a lot of patients not really familiar with the technology. They like to see computer can do a lot of things, but they also don't trust. How do I know what computer said is correct, right? So how are we going to convince patients and willing to adopt this kind of technology when they met a doctor using this technology? I think this is also a field we needed to put more emphasis on, and I'm wondering if Robert has some comment and suggestion on this specific field.
Well, I think the biggest change I believe is we have to move away from a pay for volume to a pay for value, from a fee for service reimbursement that pays you regardless of whether there's any good at all. In fact, often if there's a complication, you get paid twice, once to create it, once to improve it, to one that is going to be focusing on prevention, focusing on better management of chronic disease, focusing on earlier diagnosis, better outcomes, preserving health, lifestyle medicine. We go down the whole list of opportunities that are there. And that's, I like to think of as a capitated system. I mean, let's look at your company right now. If I understand what you do, there's three major advantages that you're providing to patients. Number one, you're going to make earlier diagnosis. So the likelihood of the disease having metastasized to elsewhere in the body will become less. The magnitude of the surgical procedure will become less. Number two, you're going to be better able to manage the dose of treatment because the more, I'll say, powerful medications you give, the higher the complication rate that is there. And then number three, you're going to be better able to follow the patient and make sure there's no recurrence, and therefore be able to intervene again earlier. Well, if you think about that in a fee-for-service world, none of that is particularly valuable. You wait a little longer, and now you got to do surgery and chemotherapy. It generates more money. If you have a patient with a recurrence, now you get to treat the patient again. And complications, get to treat the complications, or it's not a problem. It doesn't affect you economically. And I don't mean that as negative as it sounds. This is not intentional. It's just what happens. It's not how we think as clinicians. As clinicians, we think that we do everything to preserve the health of the patients, but we look at the data. That's not what occurs. The economic, as you say, the system has a major influence. Now you move to capitation. Now we have a group of a few hundred physicians taking care of 100,000 patients from all different specialties. Some are in primary care, some are sitting in urology, some are sitting in oncology, and they're all going to benefit by each of the modalities you do. If you can diagnose the cancer earlier, the cost of care goes way down, as well as the outcome, of course, getting so much better. If you can get the dose right and they don't get a complication and need hospitalization or develop a secondary infection, if you can find the recurrence sooner, you can treat it more easily. Every one of the pieces align the incentives of the clinician and the patient. That's what, to me, a capitated system does. And it's not that the fee-for-service creates an antagonism. It's just that it doesn't encourage those actions. And if clinicians don't have time in their office, what are they going to cut back on? The things that are not going to be reimbursed. And I'm sorry, it's just the reality that happens. It is part of why we have a control of blood pressure 55 to 60% of the time, or diabetes only 30%, or do such a poor job at colon cancer detection and avoidance.
Yeah, and I think what Robert mentioned a keywords is actually data. A lot of these kind of value-based things has been talked about for a long time, and conceptually it just makes sense. But why is still not being able to widely accepted and integrated into our payment system is a lot of insurance company, they're looking for data. They say we want to see the evidence, right? It sounds good, but we want to see the evidence. But it all sounds great, but in reality, this is chicken and egg chicken. If you don't have the data and the incentive, then if you don't have the data, the insurance company will not pay for it or follow these kind of things or widely adopt this. But if you don't widely adopt this, then no doctors will actually start to using this method to effectively collect a large amount of data to convince the insurance company. And then so we're making these kind of chicken, egg, chicken things over here for a long time. And even a lot of these kind of impact could be very obvious, but we just don't have those kind of information to prove. And that's actually also another thing why I decided to leave academia to start BAMF is I do believe the only way or the most efficient way to break the chicken, egg, chicken paradigm is actually somebody willing to take some risk and to just break the wall. And the BAMF over here, one of our mission is using to test this kind of model, right? We believe AI will make a huge impact. We believe this new therapy will bring up big values. But will it, and how much value it will bring it even before you're willing to give us the solid payment model, we're going to be the group trying to collect data for you. We'll find a way. And then that's what we're trying to do. And I think we will need to figure out a system to encourage more people and more organization do this kind of testing. And then we can overall facilitate adoption for those kind of value-based systems.
Let me add one little tiny piece, which is when I talk about capitation, I'm talking about at the delivery system level. That's the prepayment being given not to an insurance company, but being given to a group of clinicians. And I'm confident that it'll be easier for you to convince the other specialists in your group that your approach makes sense than to try to convince the CEO of an insurance company to pay for the treatment that's there. So I think it is such a vital first step that if there's one wave of the wand that I could make, it would be to move our reimbursement system, because I think all the pieces will fall in back behind it once we've accomplished that, and including, though people want to see data, but the data will be easier to understand and easier to act upon than if we try to do it through the current traditional insurance fee-for-service methodology.
Agree. It makes a lot of sense.
This is incredible conversation, you guys. I am so grateful that you were both willing to come onto the show and have this talk about AI and generative versus what Anthony's doing, and how we can all make this work, and why leadership is so important. I've got goosebumps. You can always tell when I'm getting excited, and I say this repetitively in a show because I start to scoot up in my chair because I feel like I'm going to hear better the words that the two of you are saying. So before we finish, we've got to do a Ripple challenge question. There are no rules to this. You can answer it however you like. I'm going to throw the question out there, and I'd like to hear from both of you. And after that, we'll do one final thought from each of you, and how people can get a hold of you. And certainly that information will be included in the show notes as well. So the Ripple challenge question is checkers or chess? Anthony.
Chess.
Any particular reason?
More complicated.
I would have bet the farm that you would have said something along those lines. How about you, Robert? What would you say?
When you teach strategy in a business school, it's always at least chess, if not three-dimensional chess or four-dimensional chess or something else that sits there. And the reason is because life is complex, and simple solutions are a good place to begin, but you have to make sure from a probabilistic fashion that they're likely to succeed. I think the model of chess is great, although Go may be even better, because you're positioning yourself on a board for the potential moves that may happen, not the next step, but many steps down the line. I think it's a more honest intellectual function and more applicable to daily life.
Totally agree. I think Go is actually way more interesting than chess, and it's more better. It's a way better way to mimic the real life. A real chess, you still can see where the enemies are, where your opponents are. In real life, you just don't know, especially you need to start new things to create it. And then Go is exactly like start from empty board, and then you just set things up.
I'm feeling a Go match developing here just as a result of this show. And maybe I'll be the referee for the match. Maybe that'll be my role.
I already solved that.
Yeah, right. Outdated already. So I'll say chess as well. And I'll maybe just give a brief story. One of my good friends from medical school and we used to play together on a team versus one of our other colleagues. His rating, I think, was over 2,000 somewhere at his peak, which is quite high. And let's just say my colleague and I think, won 1 out of 12 games, perhaps. And it was humbling, to say the least. But anyways, I digress. I'd like to offer each an opportunity for one more imparting thought, whether it's hope, optimism, really whatever you want. And how can the audience reach you? Anthony, I'd love to hear from you first, if you would, and then we'll conclude.
Definitely. I mean, it's really my great honor to be here today to discuss this topic, exciting topic with both of you, and especially meeting with the great leaders in the field, Robert. And I mean, to me, this is an inevitable future, and I feel extremely hopeful and optimistic about how big the impact AI can actually help us to offer a way better care to our patients, lower the cost to the system, and also like really achieve precision medicine. But this is not going to be an easy route. Like what we said, we need a mindset change, we need systematic change, we need a regulatory change, and we need to figure out the last mile even everything has been changed, but how to really efficient implant this kind of thing to everybody. So I mean, it takes leaders like Robert and like everybody who share the same vision to really push it, and we can facilitate that. Like what I mentioned, eventually we're gonna get there because it's inevitable. But the faster we can get there, we can benefit more patients in earlier ways. We can save way more lives, which shouldn't be lost. And that's what I feel very excited about and very honored to join this conversation today.
And what's the best way for people to reach out to you, Anthony?
BAMFhealth.com, BAMF Health.com. And
Perfect.
then, yeah, he can just looking for me, you can find me.
Perfect. And just for the audience, if I can figure out how to use ChatGPT in less than 5 minutes, probably anybody can figure out how to utilize it. And honestly, I think it would have been invaluable to offer that to my patients as a family physician. Interestingly enough, my time being full-time coincided with this coming out to the market, so I never really had that opportunity. But now that I'm back to doing some direct patient care with a very forward-thinking ER group, I've already been bringing this up. Hey, how can we start to think about utilizing this in delivering care? So stay tuned on that front. Robert, sir, the floor is yours.
Thank you so much for having me today. It's been great interacting with Anthony. I would tell listeners and viewers to remember this technology is improving exponentially. And it's hard for our brains to understand that if it doubles every year, as I said, 5 years from now, it's going to be 30 times more powerful, and 10 years, 1,000 times. But we don't wait till it becomes that much more powerful. We start thinking about now. And I want to encourage people to start exploring with it. They can get the free version of ChatGPT, and it's now GPT 4.0, which is not only just a text version, but a interactive voice version, or go to Gemini or Claude or whatever. But now is the time to start to see what it can do. When I get asked this question, and I often get asked it on the podcast, I think back to my dad, who in the first year that Apple released the iPhone, he called me up. He knew I was interested in technology, and he called me up and proudly told me that he had bought an iPhone. And I said, Dad, that is amazing. You're at the cutting edge of technology. What are you going to do with your iPhone now that you have it? And he said, I'm going to lock it in my trunk, so if I'm in a car wreck, I can call someone. That was the limitation of thinking. It wasn't just my dad. I mean, everyone at the time. It took something like 7 years before there was broad adoption. We can't wait 7 years. This technology will revolutionize medicine. And I just want to encourage everyone, whether you're a clinician or a patient, just try using it. Learn how you can ask the questions, then re-ask the questions and re-ask the questions, how you can gain true expertise. The idea that the patient is going to match the doctor, that's not going to happen. That the patient can become so much more expert and knowledgeable than today, that's already a reality, and it's just going to grow and grow and grow. I think that together we can make American medicine once again the best in the world. If people want more information, then go to my website, robertpearlmd.com, and they can sign up for my monthly Musings. All this is free, by the way. It's just for educational purposes, and they can find information on the newest articles. They can listen to the podcast, the Fixing Healthcare podcast, where we cover the new developments. But all that information is available on robertpearlmd.com. And I welcome feedback from listeners and viewers, particularly if there's anything that's not accurate. Please let me know. I want to learn along with you. Thanks for having me today, Todd.
Oh, I love that last statement. You guys are great. This is just fantastic. Keep up the great work, both of you. And I'll end as always. What positive ripple of change will you create today?
Grab your copy today. Ripple of Change is available in hard, soft, and ebook formats. More information at www.ourquadrupleaim.com. Thanks for listening, and let's turn ripples into waves of lasting change. Stay tuned to this podcast as we search for examples of our quadruple aim.